Good morning. Thank you for having me here. Yes, I'm a very proud mom. That's my biggest achievement. One in college and one junior. I know we have very little time, and I didn't see anything written. I was the only one, nothing was written about me. So I'll tell you a little bit. Actually, there's not a lot to write, so that's why. So I'm a pediatrician with an oncology background. I joined Healthcare Partners in 2000. So I've been there 18 years. We were acquired by Davita, and now we are known as Davita Medical Group, and we would soon be acquired by Optum. So I'm not the expert in technology. Believe me, I have two brothers, which I'm going to talk about, and why I came into remote patient monitoring. So we're going to talk today about reduction in admission and a lot about transitions of care and how to reduce admission, readmission. So RPM, I'm sure you guys know more about it than I do, but the part that I know is about interfacing with patients when you are conducting or you are using RPM to monitor these patients. So we're going to talk about high utilization, high cost disease states, and the need for evidence. Because what happened with us at Healthcare Partners is we actually started working with a lot of technology companies in the early 2009, 10, and we did some projects with them, and it was a total failure because we didn't really have the system readiness to do that. And the last 4 years have been very successful, and I want to share some of those successes. So one of the things I want to talk about is health factors. We all know only 10% is really healthcare, right? The rest of the time, we don't know what the patients are, what is influencing, how these changes are happening. So it was really eye-opening to do the remote patient monitoring and learn about what's really happening with these patients in chronic disease management. You know, a little bit of remote patient monitoring, and I alluded to my brothers. I have two brothers. One is a pilot, and the other one is an aeronautical engineer. And since years, I've been hearing them of using technology, and my aeronautical engineer would talk about how jet engines are really monitored from the ground. Every jet engine that, is carrying passengers, because I had a fear of flying, and he would explain these things to me. And I thought, oh my God, we as physicians can't even monitor one patient. They're monitoring an engine that carries so many patients, and they're doing a pretty good job. So when the engines, when these planes come down, they're already aware of what's going on. They can correct things. So I think healthcare, as physicians and payers and health systems, we're really behind. And there is a fear in us. Slowly, we are getting smarter, and it's going away. So I think we should be catching up pretty fast because we are smart people. So, a little bit about application to patient care. And I will emphasize in the second and the third box, care essentials, escalation protocol. So escalation protocol is a big one. If your system is ready, that's good. And if your system is ready with an infrastructure, that is the secret to the success. And then technology matters, right? So technology and the readiness of your system with the infrastructure, and you have to test it out first, so nobody is getting disappointed. It's a testing phase. And then it's really, you show the outcomes of it. You can reduce hospitalization with chronic diseases like CHF, congestive heart failure, COPD, diabetes. These are the high utilizers. So basically, we give them these devices with sensors. So what we've seen with our studies is improved quality of life and patient experience, reducing utilization and costs. Until I'm able to show that, nobody pays attention. So as soon as I show that, and with a rigor, because a lot of questions will come up, especially when you want to publish or show the data and say, see, look at the control group and look at the ones we were intervening on with remote patient monitoring. So early intervention, integration of care, coaching, increased trust, so there is workplace changes, increased productivity. And with this, what we were also able to show is that nobody lost their job because of that. We actually had to have added personnel, but the total healthcare cost is what reduced. So I don't know, the slides are coming twice. Okay, so here functions of patient care process with actionable data. I just wanted to show how repetitive it is and how the patients learn to take care of themselves, self-management, because it's very repetitive. High utilization, high cost. So these are the 4 projects I want to talk about: COPD post-discharge program, COPD admission prevention, and some of them are in progress, some of them are done. So COPD post-discharge, we did the program in California, IRB-approved study. Background is there's still, very high, very expensive to treat them. It's been the same, only the cost is increasing. We have new drugs in the market, new research, but still the cost is increasing and these patients keep going back to the hospital. So as we spoke, the rationale, the study design, IRB-approved study, we had 200 patients. This is an important slide because this is where you can see the patients that went on the remote patient monitoring. You can see 8%, and the control group who didn't have that was 18%. That equals to a lot of money savings, millions of dollars. And then you can see 60 days is the same thing. 90 days, you can see the variation. And what I also want to tell you, now we have 1 year of data, and what's really cool is the patients that were in the intervention arm, who also graduated from that arm, and time to time they know now when to reach out because they've learned how to take care of themselves. We saw 30% of death in the control group compared to the intervention group. So that is very significant, plus the cost savings. So this is a slide I wanted to show. This is what makes everybody happy. Notable differences of COPD post-discharge program. So daily monitoring, face-to-face visits, so you can tell from that. Now CHF also, we did a study with 400 patients. In this study, what we saw, so this is the primary endpoint, all-cause hospital admissions and quality of life over 1 year. And this is just the way we analyzed it by the Poisson model. And what I want to show here again is the reduction, 30% reduction in admission. And again, happy doctor, happy, everybody, right? Money makes people happy, even though they say money can't buy happiness, but it can to some extent, right? So what I also want to show is that 90-day, okay. So somehow I'm going backwards, sorry about that. So 90-day, also we saw pretty good results. Somehow I can't go further. Okay. So 57% lower in the intervention group after 90 days. Key takeaways, so this is an important statement, not in his goals, but in his transition man is great, because during post-discharge and the transition time, a lot can go wrong. So gaps in care and opportunities, there's still a lot of communication gap that's happening between hospitalist and, every time they say the communication is happening, I can assure you more and more we are learning it's not happening. So technology plays a very crucial role. The most important part is the system is ready and there is testing time given to it to do justice to the different devices and different technology that you guys are bringing as an innovative opportunity. Technology and the direction, so high-touch, high-tech approach. This is how, there's no much time to go through this, but maybe I can answer questions later. And then this is the workflow that's needed. Many times there are changes in this, but we have to create those changes, right? Alert communication, very important. How it's communicated and what is the intervention done. So remember, detection plus validation plus communication plus intervention equals to impact. And I also want to say one thing. As advanced we are in technology, we also make it more complicated. So we need to keep it simple. And simplicity means the achievement of maximum effect with minimum means. Questions?
Thank you so much. Okay.
I tried to rush. I'm sorry, and my slides didn't help me either. But I hope that was helpful.
Okay. Any questions?
You said you're a pediatrician by training?
Yes.
So how does this technology work in your pediatric patient population, and how do you engage parents?
Yes, so I'm a pediatrician by training, but I was hired by Healthcare Partners in 2000 to start a clinical trials program, research, disease management, because I'm also a health economist by background. So I'm a certified physician investigator. So that's why I'm not really doing these projects in pediatrics, but I have many ideas since yesterday, and I will be going back, and our plan is to do telehealth and remote patient monitoring wherever it's needed. We're going to test these things to find the cost reduction and then expansion and scale it up to all markets. Thank you.
On the operation side, can you explain, like, on the COPD, CHF patients, if there are some symptoms, that worrisome patient need to come to the ER, and your call center get the call, how you manage that?
So we are monitoring the patients. So when we see something is different, the alerts are going to come. And patients have a way of communicating. When we see that, we have created care pathways. So someone will get in touch with the patient in real time if they feel it's something that patient needs to be admitted, or come to see their primary care physician or pulmonologist on the same day, same time. We arrange that. If they need to go to ER and get admitted, we arrange that also.
Just two questions. One question, with the study, did you use end-stage renal disease patients, or it was just COPD patients?
No, for the COPD study, just COPD, oxygen dependent, so the very sick patients. But now we are doing another one where we are seeing high-risk patients. There's 600 patients in the study and 600 control, where high risk, they have to have a hospitalization in the last 12 months. Plus, they have to have 4 comorbidities: CHF, COPD, diabetes, hypertension, atrial fib, and mental depression. Yeah.
So then a question following this, in terms of intervention, is there is a patient mobile portal, and the devices are showing they don't look like devices that integrate through API? Do you use more like devices that are connected devices to manage patients
Connected
remote?
devices, yeah.
Adoption in terms of engagement, because there is a big part of patients being elderly. What was your experience with adoption among 600 patients? How many of them actually, how often use the portal? And what were barriers, and how did you overcome that in terms of technology adoption among those patients?
So that's a very good question, because that is key. And we did take a long time to arrive at that, and we've learned some secret sauce how to deal with that. And I will tell you, a loss to follow up is 2 patients out of the entire number, because there are members. And third thing, the engagement, it takes time to educate them, and it's really how, again, the system readiness, what kind of support and resource you have to achieve that. But at the end of the day, the most important, what I showed you, that 30% reduction, and the savings was so huge, even when we added more people. So technology does make it efficient, but are you ready? And is it simple? And have you tested that out? And do you know what are your shortcomings? Then there is an impact.
Maybe one last question.
Okay.
This is just about the study design. When you saw such a big reduction in mortality, wouldn't it be good to just stop the study and switch over the controls?
We did that. Very good point. Yes, what we did is we saw this great results, and we said, why are we waiting? We should be going ahead, and so that's what we're doing. We've expanded it. We are not just sticking to post-discharge. Thank you very much, and I'll be out there. I can answer questions.
Thank you so much. Okay.